Good afternoon, everyone. My name is Lauren Wilson. I work at the Christ Hospital within our Population Health Department. Thank you for joining us for our Heart Health Seminar presented by Dr. Menon and Dr. Quesada, two of our cardiologists at the Christ Hospital. A few housekeeping rules. You will be muted throughout the duration of the seminar. If you do have any questions or comments, you can put them in the Q&A box you find at the bottom of your screen. We will have time for questions at the end of the seminar. Our discussion today will include hypertension, atrial fibrillation, and cholesterol. Dr. Menon will also review risk factors specific to South Asians and how they can manage their heart health. Dr. Quesada's discussion will highlight how heart health differs from men to women, her ongoing research and treatments, as well as the Women's Heart Center at the Christ Hospital. And with that being said, I will let Dr. Menon go ahead.
All right. Great. Thank you so much, Lauren. Let me get my slides up. Can you see my slides?
Yes, we can.
Okay. So really, I'm going to focus on prevention of cardiovascular disease, what we call heart attack, stroke, and I can touch base on AFib. I don't have slides on atrial fibrillation, but we can talk about that. I apologize for the typos. There's a couple of them. So just to talk about the magnitude of the problem of heart disease, it is the #1 killer of women and men. And Dr. Quesada will emphasize the importance of women across the US. And it seems to be waning a little bit in the US, but in other countries, especially where I come from, India and all that, and South Asian countries, it is growing exponentially, and it's going to be the #1 killer for quite some time. Really, over 1 million Americans suffer from a heart attack or a stroke every year. That's a large number. And really, when you look at the numbers, it kills more Americans than all cancers combined. We put a lot of emphasis on breast cancer, prostate cancer, so on, but really the #1 killer is heart disease. Let's see, next slide. Apologize. So when you look at the map of the whole world, the more red it is, the more incidence of heart disease is prevalent. When you look at the United States, it really is not too bad, 95 to 135 per 100,000 men. But when you go into Asia and Russia and some parts of Europe and Middle East, where obesity, type 2 diabetes, sedentary lifestyle all are on the rise, the incidence of heart disease continues to grow. And this is translated when they move to another country. Like, for instance, if they move from Saudi Arabia to United States or India to the United States, your risk does not go down. So there must be a genetic component. Well, what causes a heart attack? What is the crux of the problem? This is applicable to not only heart attacks, but stroke and peripheral vascular disease, where you get blockages in your legs. It is this thing. This is a cut section of the coronary artery, or any artery, the artery that goes into your neck, such as the carotid artery or the arteries in your leg. When you're born, there's no real blockages or anything. Over time, you develop where the cholesterol is deposited in foam cells, as we call them. And over time, this builds up. It causes a blockage. And what causes a heart attack is a clot here, and that cuts off circulation to the heart or to the brain, and you get a stroke or a heart attack. And this happens over decades. And you'll see in some people, some populations, such as South Asians, this happens in a much shorter period. But this is where all the action happens. This is where your cholesterol pill works, your aspirin, and so on, is to protect this plaque. So when you hear about heart disease, you don't know, a lot of people don't have any symptoms, but people are worried about it. They have a family history of heart disease, or they have high blood pressure, diabetes. Well, what do I do to reduce my risk of having a cardiovascular complication? We're talking a lot about prevention. It's easy enough to put a stent, to do bypass surgery, but we want to prevent it much before then, to prevent you from having any problems. Because once you have a heart attack or a stroke, not only if you survive it, you're lucky in a lot of times, but also the disability that comes with it, not being able to do the things you want to do, not being able to go back to work. Those are all tremendous factors. So our goal in our practice is to really prevent this from happening. So what can you do? Most important is see your doctor. Don't see them once in 5 years or when you need them. See them regularly, once a year, even if you're healthy. Make sure you get your cholesterol checked. Even if you are a 40-year-old marathon runner, you still should have it because there are some genetics that cause severely elevated cholesterol that needs to be checked. And you usually don't have symptoms till that plaque ruptures and gives you a heart attack. And then by that time, sometimes it's too late. And as for subparticles, as we call them, those are not part of the usual lipid panel, what we call LP little a, ApoB. These are all very what we call arthrogenic particles in the lipids. That is what causes the blockages. And some of my patients, I check inflammatory markers. That is not the inflammation that you get in your joints, but there's a couple of them that called HSC, C-reactive protein and homocysteine, which are elevated, which also tells you that really the biology of the blockages in the heart or in the carotid is a lot of it is inflammation. And cholesterol pills such as statins and all that reduce not just your cholesterol and your LDL, which is the bad player, but they also reduce inflammation. They reduce the inflammatory markers, which is crucial. LP little a does not respond to a statin medication. That's a whole different discussion. They actually only respond to one of the new injectable medications, monoclonal antibodies that we use now to lower lipids. Well, what happens if you have high blood pressure? You got to watch your salt intake. Americans taking the most amount of salt out of almost any population. The closest next one is Chinese. And it's all in our food, especially if you eat processed foods that is very high in salt. It'll make your blood pressure more difficult to control. It'll cause you to retain fluid and so on. Read the label. Now, let's say, you know what, you have a family history of heart disease, but you feel fine, but you're worried. Ask for what we call non-invasive imaging. What means is that we don't put a needle in you or a catheter. You can get simple tests such as a calcium score, which is a CAT scan of the heart, which takes about 7 minutes to do, no IVs. And it tells you how much plaque, that those pictures I showed you, that tells you how much plaque you have. And your doctor can treat you accordingly to what can cause the plaque to be stable, as well as to maybe even cause regression of it. Start exercising. There's no downside to exercising, and I'll show you some slides on that. Quit smoking. If you're a smoker, there's no upside again of vaping, smoking, marijuana, and so on. Those do cause plaque buildup all over. And even if your cholesterol is normal and you're healthy otherwise, if you're smoking, you just increase your risk exponentially. Lose weight, figure out your ideal body weight. This is the toughest thing that most patients do in my practice. But there are many ways, and I'll go over that, and how to lose weight. And your doctor can figure out what is your ideal body weight. Some of the diets really don't work, such as keto diet and some of the other ones, but ones that work, I will show you. And if you think you're having a tough time losing weight, to join Weight Watchers, which has really been shown to work, or see a dietitian. Sometimes your insurance company will cover that, sometimes not. They will help you with the healthy lifestyle eating. Stress, we're all under a lot of stress, whether it's at home or at work or in our personal lives. Stress does increase what we call the inflammatory markers, that is the hsCRP and homocysteine, and that causes more cardiovascular risk, believe it or not. And among South Asians, the stress level is much higher than it is amongst the white counterparts. Control your alcohol intake. I'm not saying stop drinking alcohol, nor am I asking you to take something to prevent heart disease, but it's a J-shaped curve. So you do reduce your risk a little bit, but as you drink more, the risk goes up, not only for heart disease, such as blockages in the heart, but also weakness of the muscle, what we call cardiomyopathy of the heart muscle, or atrial fibrillation, a very common cause of atrial fibrillation in younger and middle-aged people. But these treatments have to be tailored to you. So you have to get all this information. What I'm trying to do, what we're all trying to do, is empower you to ask these questions to your physician. Going there and not saying anything, you feel fine. Don't take that. Don't go like that. I mean, and some of the hints are like, get your blood drawn before you go to see the doctor. Make sure it's fasting. I always think it's fasting is better, because most of the studies we've done is in fasting states. Exercise, you can't, there's no downside to it unless you get hit by a bus while you're running. But really, it's a win-win for you, and I'll show you some of the benefits of it. Eating, I mean, we all like to snack, we like to eat everything, and if food is available readily, you really are what you eat. Physical activity, well, what are the benefits of that? Well, some of the benefits include maintaining a healthy weight. if you're at an ideal body weight that is for your height, you reduce your risk of any cardiovascular complications, you reduce your risk of diabetes and so on. It lowers your blood pressure, believe it or not. You can't just take a pill and not exercise. You'll find it much more difficult to control your blood pressure. It helps control cholesterol. Studies have shown that 30 minutes a day, 4 to 5 times a week, actually reduces your cholesterol, maybe increases your good cholesterol, which is your HDL. It also reduces your blood sugar levels. If you lose weight, if you're a pre-diabetic and you get to your ideal body weight, you reduce your risk of developing diabetes, which is a tremendous risk factor for heart disease, because diabetics die of heart disease, not of diabetes. You can reduce your risk by getting to an ideal body weight and exercising by almost 20 to 30%, which is a large amount. So it's a win-win for you to lose weight and exercise. When you look at the Surgeon General recommendations, which was what we all follow, 2 hours and 30 minutes of moderate intense exercising every week. And what I tell my patients is, pick an exercise that you enjoy, that you can do again and again, and stick to it. Make it like a habit, like you're flossing your teeth or brushing your teeth every night. Make sure you exercise either early in the morning or in the evening, whenever you have time, and you'll feel much better. I've never had a patient tell me I feel worse after exercising. And many of my patients, they stick to it for many years and they feel much better, and they improve their cardiovascular risk. And children and adolescents, they're also at risk for heart disease, especially if you have a family history. Children and adolescents, as they become more sedentary, they should also get 1 hour exercise every day, especially in physical education class and so on, and putting them in sports is a win-win. Well, how do I improve my diet? Again, just to emphasize, you are what you eat. You can eat smart. Eat less calories, count your calories, look at the package label, it's very important. Eat less foods with saturated fats, and you really 20 to 25% of your total calorie intake should be from saturated fats. That is fried foods, donuts and things like that. And those that are cooked in vegetable oils, especially where we come from, we use a lot of coconut oil and all that. It's very what we call arthrogenic, meaning that that's what causes plaque at a much earlier time. At a much earlier age, rather. Eat high fiber foods. When you eat high fiber, you prevent the absorption of glucose or of other carbohydrates. It slows it down, so it gives the body time to digest it. Because if you take in too much, a lot of carbohydrates, and your body doesn't need it, it'll convert it to fat. It'll be stored as fat. Eat whole grain foods, and I'll show you a pyramid. Vegetables and fruits and beans are win-win for to help maintain ideal body weight and reduce your cardiovascular risk. Drink lots of water. Studies have shown that when you're hungry, a lot of times it is thirst rather than hunger. Try drinking some water. And again, as I said, reduce salt intake if you have high blood pressure or a high tendency towards high blood pressure. The oils to use are olive oil and canola oil. Those are very much protective. And also eat foods rich in omega-3 and omega-6. That's why Japanese and Chinese are protected, because they eat a lot of fish. Even though a big percentage of them smoke, they have a high intake of omega-3 and omega-6. If you're a vegetarian, don't want to eat fish, you can take omega-3. Really, we don't recommend those over the counter because they're not regulated. You're not sure what you're getting and what are the additives in it. But sometimes a prescription such as Vasipa, which is a new omega-3 and omega-6, is quite beneficial. Soft drinks, a lot of us drink diet drinks. We need it for the caffeine. We like the bubbly taste. Really, it actually increases your hunger, makes you want to eat more, makes you dehydrated too. And sugary soft drinks, goes without saying, that is always converted to fat. A Mediterranean diet. This is one of the diets we recommend. If you look on the Christ Hospital website, there's a great handout that you can download and print. It tells you how to follow a Mediterranean diet. Studies have shown that people who eat a Mediterranean diet actually live longer when everything else is equal. So these kind of things are the foods that are in it are a lot of green leafy vegetables, some nuts, beans. But a lot of people think that there's no meat in Mediterranean diet. There's actually lean meats, and you can eat meat, so you don't have to become a vegetarian. In South Asia, actually, there's no benefit to becoming vegetarian. But eating a high fiber, wholesome diet, our bodies are made to break this kind of stuff down. It's not made to break down Big Macs and Whoppers. So it's a win-win. This reduces inflammation, this sort of diet. And Dr. Casado is kind enough to send me the slides. This is what the American Heart Association follows, Life Simple 7. So really, if you go around from in a counterclockwise fashion, stop smoking. It's easy for me to say, but it's a win-win for most of my patients. Eat better, as we had discussed, lose weight. If you lose a pound a month, that's really good to an ideal body weight. And that'll help in turn control your cholesterol, but have your doctor check your cholesterol. Have him or her check your lipids, your LP(a) and all that. It's very important. Get active. Anything that keeps you moving. If you're working a lot and you work a lot, like many of the doctors here, park further away, use the stairs. That stuff does pay off. Sitting is considered the new diabetes. All of us sit at work or at home, and movement is key. If you're working and if you don't get a lot of breaks, I tell my patients, if you can take a 5-minute break every hour and walk around, that helps. And that in turn will help you reduce blood sugars. You got to watch your carbohydrates, keep your blood sugars under tight control, because otherwise, if you don't do that, your cholesterol will go up and really you'll have either a heart attack or a stroke. And then of course, manage your blood pressure. So this is again another slide on exercise. Basically, what are the benefits you can get if you do 150 minutes of moderate intensity exercise, 75 minutes a week of vigorous? It's a win-win. The key is to make it into a habit, to make it regular, not to do it once a week and try and run 10 miles. It's just of no benefit. And try and sit less, as I discussed. The sitting is considered the new diabetes, and the more you walk, the less you sit. But we're all tied to our desks. I think you have to make time to do a little bit of walking, and also some intensity. Once in a while, a little bit of getting your heart rate up is a good thing. Add resistance training. I tell a lot of my South Asian women that resistance training, you don't have to buy dumbbells and all. There's a little bit of weights or bands, and that helps build tone, that helps protect the bones also. And there's no downside to losing weight and exercise. It helps reduce stress, helps you sleep better, your joints feel better. So movement is what I tell my patients is life. Looking at the Mediterranean diet, they do limit red meats, but like I said, limit, you don't have to get rid of it. And some eggs and dairy 1 to 2 times a week. Really push hard on the seafood rich in omega-3s, such as anchovies, salmon, other types of fish, and every day eat fruits and vegetables. The more raw, the better. If you cook it, you boil it, and it doesn't crunch, it is of no benefit in terms of heart health or protectiveness. Olive oil is very important. And again, red glass, as American College of Cardiology, which is our governing body, doesn't go against it. But if that's what you want to do, that's fine. But you have to limit it. You have to control this. Everything in proportion. And some of my patients, I tell them, well, if you have a 1-day cheat day, as The Rock has, as you can see on Instagram, it's perfectly fine, but just not to go 3 days of cheat days. 1 day is fine. That'll reduce the craving for all these foods that we like, such as ice cream, pizza, and all that. Just to change gears now, I'm going to talk a little bit about something that is very I'm passionate about, because I am, as you can tell, of South Asian descent. It's talking about the cardiovascular complications. South Asia is really empowering our community. South Asians are those that are from India, Pakistan, Bangladesh, Myanmar, Bhutan, and Tibet, and Nepal, and Sri Lanka, and possibly other Bangladesh, and of course, maybe even Afghanistan. And believe it or not, our mayor is actually South Asian. So what is the problem? What is the issue with South Asian? And this extrapolates not only living in India or another country, but also living in the United States, even if you're second generation. We make up 25% of the world's population, but we account for more than 60% of the world's cardiac patients. That is heart attacks, bypass, valve replacement, so on and so forth. And it is a leading cause of death in India, Pakistan, and Bangladesh, and those rates continue to rise. And they occur younger and younger ages. In the US, we're one of the fastest ethnic growing populations, as you know. And when you look at some of the data, some of the studies that were done in the US, that our risk for heart attack is 4 times the normal US population. It occurs 10 years earlier. So you can see I see a lot of South Asians who have heart attacks in the 40s and 50s who are healthy otherwise. And once we have a heart attack, that is, a South Asian has a heart attack, they have a 40% risk of dying from the heart attack. So once we have it, we don't survive it, or we're tremendously debilitated by it. And we think that by moving to the United States or Canada or wherever, that we reduce our risk, but there's no change whatsoever. And this all happens in one generation. Well, why does it happen? What is the problem? That picture I showed you of the heart plaque is the same for everybody. That is the keystone of how everything happens. But why does this happen? A lot of South Asians, and this continues to grow, are pre-diabetic. We have metabolic syndrome where our blood sugars are elevated, our triglycerides are high, our HDL, the protective cholesterol, is low, and our LDL is pretty much okay. But we're not obese, but we're just out of shape. Type 2 diabetes is an epidemic proportions in South Asians. 120 million South Asians will have it by 2030. And it's at least 4 times more prevalent in South Asians versus Caucasians in the US. We also suffer from low HDL, and we think that some of the HDL particles, which is protective, and Caucasians tend to have very high HDLs naturally, that the low HDL in South Asians is also very arthrogenic, that is what causes plaque. And we also have a very high elevated LP(a), as I talked to you about. And but usually doesn't get checked. We show up at the doctor's office, we don't have high blood pressure, we don't smoke, we're thin for the most part, and everything goes under the radar. So everybody thinks you don't have a risk. Nobody checks the cholesterol, nobody checks the (a) or your blood sugars, and till it's too late. And we tend to keep our fat inside near our bellies, which is what we call more arthrogenic. It is because of our diet and the diabetes and the lack of physical activity. What we have seen is that we are much more sedentary when compared to our counterparts. And as we become, studies have shown, as we become more successful, whether it's at a job or at a university, the less walking we do. We have a high incidence of high BP blood pressure that goes untreated. We also have a very high inflammatory markers. I check that in all my South Asians. There may be a possible genetic component. When earlier on, when there was a lack of food, maybe about 100 years ago in India, we would, or any of the South Asian countries, our genes would help us store all the calories we took. So we didn't know where the next calories came from. And that gene continues now, but we're not as active as we were, and we eat a lot more, and we eat a lot of what we call glycemic foods, such as rice, which is low in fiber. And that leads to higher sugars, and that leads to diabetes, as well as high cholesterol. So because of the interest, myself and Dr. Bhatia, one of our new partners, have started a South Asian cardiovascular clinic geared towards South Asians, people basically who look like the two of us. And we really emphasize personalized care that works for them. I emphasize a lot on diet, exercise, whatever exercise works for you. You would not believe it, but a lot of South Asians have a cultural barrier and also a language barrier. So they're hesitant about seeing a physician, but when they see someone who looks like them and sort of talks like them, they feel much more comfortable. That is what we do. And we have it up at Montgomery, and the phone number is there. I'm not trying to capture patients, but what I'm trying to tell you is, one more slide, is that you have to empower yourself, whether you're Caucasian, African-American, Chinese, South Asians. You should ask your physician these questions. That's what they're there for. You should go prepared, ask them to check this and follow up, look at your results and ask them, why is these numbers like this? What can I do? What is a resource that I can use to really reduce my risk of cardiovascular disease? I want more information. I want some more tests that tells me my risk. As you know, at Christ Hospital, we do the calcium scores. We also do the vascular screening for $30, which I think is quite useful in the right context. So really, we're here to empower you. And really, I think that's my last slide. And I'm happy to take any questions, concerns, opinions. And Dr. Quesada is ready.
Yes, hello.
I can wait till the end. So let Odemi talk. Odemi, it's all yours.
Perfect. Thank you so very much. And it's an absolute pleasure to be with you here and talk about heart disease in women. Thank you, Santosh, for that great presentation to get us started. So my name is Dr. Quesada. I am the medical director of the Christ Hospital Women's Heart Center, and I subspecialize in women's cardiovascular disease. And we'll go over that during this presentation. So as you see here, cardiovascular disease unfortunately remains the #1 cause of death in women in the United States. And this is a picture that I took from the New York Times. This, if you look at the data, is in small, is from 2003. And it pretty much states women and heart disease is your biggest worry, breast cancer. Think again, 1 of 3 women will die of heart disease. And sadly, that was an article in 2003. And now in 2022, we're still in the same place. Whereas you can see here, cardiovascular disease is the #1 killer in both men and women, and it surpasses cancer significantly, as you see on these graphs. Unfortunately, despite this important fact, we know that there's been a decrease in our awareness of heart disease being the #1 killer in women. So they did a survey in 2009 and then repeated it 10 years later in 2010. And unfortunately, our knowledge that heart disease is the leading cause of death in women has gone down from 65% of people being aware to 44%. And I can only imagine how much lower it's going to be if we did this again. Right now, especially with COVID taking over in terms of our concerns and people not thinking about heart disease as much as we should and used to. The greatest decline in knowledge is among Hispanics and non-Hispanic Blacks. Unfortunately, even awareness of heart attack symptoms has declined, not only among people, but also among healthcare providers, which is equally concerning. And so when we talk about women's heart disease, people think that women and heart disease is the same, but the reality is there's significant differences when we talk about women's heart disease compared to men's heart disease. And I'm just going to highlight a few of those during this talk. So let's start with risk factors. So we know that there's the traditional risk factors that Dr. Menon went over that are very important, and we know increase someone's risk of having a cardiovascular event, meaning a heart attack, a stroke, etc. So those are diabetes, smoking, being overweight and obese, not being physically active, having hypertension, having high cholesterol. So we know these are all your traditional risk factors. But very interestingly, there's now an increase in our knowledge about these emerging non-traditional risk factors. And if you look at them, a lot of them are more specific to women. So for instance, what are we talking about? We're talking about these adverse pregnancy outcomes, meaning if a woman has had a pregnancy that's complicated by either preterm delivery, high blood pressure, pregnancy, preeclampsia, gestational diabetes, we actually know that that is a risk factor for them developing heart disease later on at a higher rate. Other illnesses that are more common in women, like autoimmune diseases, are being linked to cardiovascular disease, breast cancer treatment, and then last but not least, anxiety and depression, which is not unique to women, but more common in women. And so here we go a little bit deeper into pregnancy, because people don't realize that if there's a complication of pregnancy, that could be a clue. And we often talk about pregnancy as the first stress test in a woman. And if a woman develops these adverse pregnancy outcomes, it's as if they're failing that stress test. And that's a clue that they're going to have higher risk of heart disease later on, and also that they can actually develop heart disease at a younger age. So new data showing that. So if a woman has failed their stress test, meaning if they've developed these adverse pregnancy outcomes, that is a risk factor that now we need to take into account. And this is relevant because more than 80% of women have at least one child in their lifetime. And this is just to highlight that we have made some progress in the field, and now we have it in our guidelines. So in our ACC, American College of Cardiology, American Heart Association 2018 guidelines, cholesterol guidelines, we see that there is recognition of these risk enhancing factors, which are the ones that I mentioned, the pregnancy related conditions, and chronic inflammatory diseases like rheumatoid arthritis, HIV, AIDS, psoriasis. Again, the rheumatologic ones more common in women. And so, when we talk about these different risk factors, it's really a balance. And I tell people there's the traditional risk factors, which in a lot of them, patients have changes they can make to improve those, especially as Dr. Menon explained, if you smoke, it's critical to quit smoking. That's like, the number one risk factor and cause of cardiovascular disease. But then there's all these other risk factors that we have less control over: adverse pregnancy outcomes, early menopause, autoimmune disorders, psychological stress and depression. And so it's really a balance. So if you have these risk factors, how do you bring that balance back to baseline? Well, really, what we recommend is, that we modify the traditional risk factors, as Dr. Menon indicated, that patients know their numbers, your blood glucose numbers, your blood pressure numbers, your cholesterol numbers, the importance of physical activity, the DASH and Mediterranean diet that Dr. Menon went over, increasing sleep. There's more data actually talking about sleep as a risk factor, and when people don't get the recommended hours of sleep and good sleep, actually quality sleep, that's actually starting to be connected with also worse outcomes when it comes to cardiovascular disease. So again, there's things that we can do to bring that balance back to baseline. And of course, if a statin is recommended, which, if based on the guidelines, someone should be on a cholesterol medication to decrease their risk, then we should definitely do that. And just to kind of pause for a second and just put a plug for statins, because we do get a lot of patients that come for preventive visits. And then when we recommend a statin based on the guidelines, they're a bit resistant given the bad press that statins get. But the reality is that statins are the reason that we don't have, heart disease is the number one killer. And you saw the percentages. If we didn't have statins, that percentage would likely be double. And so statins have been proven over and over again to be safe, and proven over and over again to decrease heart attacks, strokes, and really improve outcomes, especially in patients that are high risk. So just putting in a plug for statins, if your doctor recommends it, just know that there's really good data and that they are safe. And again, one more thing to share with you about statins. There was a study done, I believe now it was 2020, which showed that placebo versus statins, patients on the sugar pill and the placebo had more muscle aches and more symptoms than patients taking a statin. So again, just putting in a plug on if it's recommended based on the guidelines, to definitely agree and take that important medication for reducing your risk. Jumping on to the next difference, we're talking about differences in clinical presentation. This, I think a lot of you have probably heard, because we are in Heart Month, it is February. So there's been a lot of awareness that's been brought about, what are the major differences between men and women? And people always talk about the presentation of a heart attack or the presentation of a stroke. So I just wanted to highlight that at the current moment. So we all know of the classic heart attack symptoms, hopefully the chest pressure that sometimes radiates up the neck, down the arm, sometimes nausea, vomiting, pretty severe. Usually people know to recognize it as a heart attack, and that is less common in women. Women are more likely to have non-specific symptoms that also mean they're having a heart attack. Nausea, vomiting alone, jaw or neck pain alone. They can have difficulty breathing, extreme fatigue, indigestion. And these could be the only signs that a woman is having a heart attack. So I always say, if you don't feel right, if something just doesn't feel right, even if you don't have a classic symptom, it's important to advocate for yourself and go get evaluated, because we know that every minute counts when it comes to heart attacks and strokes, okay? Talking about strokes, again, strokes is, a lot of us recognize if there's face drooping, arm weakness, especially on one part of the body, difficulty with speech, difficulty with vision, trouble walking, severe headaches. We know usually that those are symptoms of a stroke, but we have to also recognize other symptoms that could be harder to detect and more common in women that could be a sign that a woman is having a stroke. And that could include general weakness, just feeling disoriented or confused, memory problems, and again, fatigue can be as vague as just fatigue for a woman who's having a stroke. So just very high index of suspicion. If you don't feel right, if someone, a colleague, a friend, a family member tells you they don't feel right, even if it doesn't sound classic, advise them to go check out as soon as possible because every minute counts. Then I want to jump into another area, which is that, believe it or not, there are differences in heart diseases that affect women. So I want to be clear about one thing when I say this. We know that women and men have the classic cardiac diseases, and heart attacks, the same ones that men have from obstructive disease, happen in women, of course. We know that women get heart failure. We know that women get atrial fibrillation. So a lot of the major diseases that you probably have heard about because family members have it or just from learning about it on the news, etc. So women have those diseases too. So I'm not saying they don't, but what we want to make sure that that the people on this seminar are aware of is that a woman can also have other diseases that could explain their symptoms and not be the common diseases, and it's just because these are more common in women, and therefore we have a little bit less data. Well, we have a lot of less data on them, and we don't really know. We need to do more research so that we can learn what is the right approach, what is the right treatment for these, but they are real heart diseases. It's just that they're more common in women than in men, and sometimes they're easily missed. So what am I talking about? So in a woman, so if a woman is having angina, and when we talk about angina, it can be any of the things that I described earlier. The classic is some kind of chest pressure, discomfort, pain. But again, like I said, not all women have that. Some women can just have jaw pain. They can just have arm pain. They can have the fatigue and digestion. And it also depends on what context they're having these symptoms. And they're having them when they're doing some kind of exercise, that makes us think of small vessel disease. If they're having it random, that could be because of a different type of small vessel disease. So essentially what I'm talking about is if a woman has chest angina, whatever that angina equivalent is for them, and it's bothersome, it's affecting their quality of life, and they've already had some workup where they've either had a stress test that was negative or even an invasive test looking for blockage of the arteries that showed no blockage, that doesn't mean they don't have heart disease causing their chest pain. And that's critical to emphasize today. And that's because of what I alluded to. Chest pain or angina can be caused by the little small vessels that we don't think about often in the heart, and that's called coronary microvascular disease. And so if a woman has angina and a negative stress test, or angina and even a test that shows no blockage of the heart arteries, they could have underlying small vessel disease, and that often requires an expert opinion and definitely some specialized testing to give them that diagnosis. And so this picture just highlights that when we're looking at an angiogram, like when we even do an invasive test, we're just looking at a luminogram, meaning we're just looking at the large arteries. We're not really able to see what we see on the left here, which is this very intricate system of microvascular system. All these tiny little arteries, we don't see them, and we don't evaluate them during a normal angiogram. So that's why, even if that's negative, we still have to be suspicious that something could be happening related to the arteries, but the little arteries. And then I want to also highlight, because I know a lot of people probably haven't heard this before, which is that a woman can have a real heart attack and have no blockage of the coronary arteries, meaning no significant blockage of the large epicardial arteries. And again, this is something that hasn't been recognized until the last, I would say, last few years to a decade, where we're finally realizing that If someone has a heart attack and no blockage of the large arteries, meaning they didn't have any significant blockage, they didn't need a stent, it was still a heart attack, and we should still take it very seriously, because I actually just submitted a paper to one of the biggest journals showing that a woman presenting with an ST elevation MI, so a significant heart attack, are actually at a higher risk of death at 1 year than, well, actually men and women, so all patients with a MINOCA event had a higher risk of death at 1 year than patients who actually had a blockage that they were able to get a stent for. Okay, so definitely very important that if someone had a heart attack and was told, don't worry about it, there was no blockage, that that they should worry about it and seek expert opinion, because they had likely a MINOCA event. And that's, I'm not going to go into the details of what causes that, but just to know that there's particular etiologies that are responsible for someone having a heart attack without blockage in the heart arteries, and these are more common in women. So MINOCA is more common in women, and these different things that can happen, like spasm, spontaneous coronary artery dissection, stress cardiomyopathy, those are more common in women, as is the MINOCA events. And last but not least, I wanted to just highlight that unfortunately, even when we know how to take care of a woman with heart disease, like let's say a woman has a heart attack, we know how to take care of a heart attacks. However, as you see here, unfortunately, there's gaps in the care that women get. So they're less likely to be put on the right treatments that we know work for heart attacks. Or if they have heart failure, they're less likely to be on treatment. Or if they have atrial fibrillation, they're less likely to be put on a blood thinner to prevent strokes. If they have high cholesterol, they're less likely to be on the right treatment or have their cholesterol levels checked. So again, important to be an advocate for yourself. If you are a woman and have some of these traditional diseases that we do have treatments for, that you're on the optimal treatment for these. And the unfortunate truth is that all these gaps, these differences between men and women, plus the gaps in care, really impact the health of women when it comes to heart disease. And as you see here, the mortality trend continues to increase. Males is higher in blue, but women is not too far behind. And we're still not seeing a plateau in the mortality of women. And then on the right, you actually see a slide that shows a recent study that was done that actually showed in young women that there was a higher risk of dying after being discharged with a heart attack compared to men. And unfortunately, COVID-19 pandemic is only increasing this gap for women. So, I tell people this, and sometimes I get people look at me like, really? Which is the fact that if you're a woman with heart disease, you are at a higher risk of having worse outcomes than if you're a man with heart disease. And that's a reality that we have to change for heart care in women. But the bright side, just going from a downer to an upper, is that 80% of cardiovascular disease can be prevented. And that's what Dr. Menon shared with you, some of the slides that go over the Life Simple 7 of the American Heart Association. And the idea that, a woman needs to put themselves first so that they can be able to take care of the rest of the family. And Dr. Menon did a great job going over this, so I'm not going to repeat it. And so last but not least, just to share with you that we are very excited that we have the Women's Heart Center here at the Christ Hospital. And it's really a center that's focused on clinical excellence. We do a lot of clinical research to help move the field forward. We're leading in terms of education at multiple levels for women's heart disease, community outreach events, and then of course, fundraising to make research and community outreach events a possibility. Here's our Women's Heart Center team. I lead it as the medical director. We now have a manager, Michelle Hamstraw, our two wonderful nurse practitioners, Darlene and Julie. And then we have Dr. Tim Henry, who does our advanced testing for small vessel disease, Dr. Mazur, who's our advanced imaging expert. our clinic manager, our nurses, and just an incredible team, including also our research associate. We have multiple programs as part of the Women's Heart Center because the idea is we want to provide a comprehensive care for women. So we have our subspecialty heart clinic for women where we specialize in the diseases that I went over: small vessel disease, myocardial infarction with no obstructive coronary artery disease. We actually have a program for that now for both men and women. We have our coronary microvascular disease program, our small vessel disease program. Again, that's actually for men and women. And then we have our intrapartum and postpartum heart health program, because we know that these adverse pregnancy outcomes increase the risk of heart disease in women. So we want to make sure that that we're doing good prevention in that group of young women. We also have our preventive cardiology program, and actually Dr. Menon is part of the cardio-oncology program. It's not part of Women's Heart Center, but we always like to promote that we do have this program available at Christ. And then this piece is just the emphasis on the importance of clinical trials. And I just want to, with these 47 participants that are on this call, just share with you, the importance of being part of clinical research. If you're invited to do it, or if you have the capacity and the ability, we are very behind when it comes to heart disease research in women, especially for these women, these disorders, these cardiac diseases that are more common in women. Those are the ones that we actually have very little guidelines, very little treatments, just because we don't have the data. So, and the reason we're so behind is because it wasn't until 1991 that Dr. Healy, the first NIH woman, the first woman to be a director of the NIH, launched the Women's Health Initiative. And it wasn't until 1996 that we were really studying women's ischemia syndrome. And that was 1996, so not that long ago. So more needs to be done. We need more women in research trials so that we learn how to best treat women with heart disease. And with that, we have a lot of research studies that we're very excited to share with you. I'm just going to highlight the two that I think is more applicable to a group like this. So we have our hypertensive disorders of pregnancy study, meaning that if a woman has had a history of preeclampsia, we definitely want your help to help advance the field in this arena. We know that women with preeclampsia have a higher risk of heart disease, and what this study is trying to do is figure out why are they at a higher risk of heart disease. And so we want women that are healthy with healthy pregnancies to help us compare the women that have the history of preeclampsia in pregnancy. And it's for women that are between 2 to 10 years since their last pregnancy. So if you're between 2 years and 10 years from your last pregnancy, we encourage you to reach out to us to be part of this research study. And we do pay for your time, and of course, more importantly, help the field move forward. And then last but not least, we actually have a study for women who have chest pain or their angina. It doesn't always have to be chest pain. Like I said, it could be other angina equivalents. But if a woman has angina and they don't have any blockage in the large arteries, that is INOCA or ANOCA, angina with no obstructive coronary artery disease. And essentially, this study will pay for a free CCTA to rule out obstructive disease in these patients. And what it's trying to do is determine if we treat women more aggressively with aspirin, statin, and an ACE/ARB inhibitor, can we decrease the risk of major cardiovascular events compared to women that are treated like they would normally? Meaning a lot of these women with chest pain and no blockage in the large arteries get told there's nothing wrong with them and are treated with no medication. So this will be a very important study in the field for women who have INOCA or ANOCA, meaning chest pain or evidence of ischemia with no blockage in the large arteries. Again, if there's an interest, the phone number to our Lindner Center is going to be at the end. And then last but not least, I want to share that we do have a Facebook group as the Women's Heart Center, where we get to put some posts about some of the things that were talked about today, heart health, heart healthy tips, talk about, put some information on the diseases that we specialize in. And so here is our, like I said, our Facebook group. Feel free to join. We're excited to have women and even men in there. I mean, it's really not close to anybody. If someone has an interest, we invite you to be part of our Facebook group. And then, yeah, just closing with the fact that it is Heart Month, almost coming to an end. So I appreciate all of you being on the call, and please help us raise awareness about heart disease in women. All the people that are with us this afternoon now know a lot about heart disease and how it's different in men compared to women. And so we really want you to be advocates for your friends, colleagues, and keep spreading the word so that we can increase awareness about heart disease being the #1 killer and the fact that it's different. And here are some of the phone numbers. Our Women's Heart Center phone number is here if anyone wants to be seen in our clinic. Our Linder Center of Research phone number if anyone's interested in our research studies that I talked about. And then just to let you know that we do have our Women's Heart Center website, and all you really need to do is just Google Christ Hospital Women's Heart Center, and you'll come to our website, which has a lot of really valuable information. It has our education material, it has all of the studies that we're part of, it has our phone number, and a lot more background on the Women's Heart Center. So a great resource for anybody that has questions about our Women's Heart Center. And with that, I will open it up to questions.
Thank you, Dr. Menon and Dr. Quesada. It looks like we do have a couple questions in. The first question that came in is, what is typical calorie intake per day? Either of you could answer.
Usually it's between 1,200 to 1,400 is what we recommend. What's more important is if you, yeah, it's also, again, the proportion of calories, where they come from. As I talked about, saturated fats have to, if you want to lose weight, it has to be less than 20%, 25%. It has to be palatable. You know, and there's a couple of ways you can reach it. One is by reducing how much calories you're taking. You count the calories, which is very good. This is what Weight Watchers does, and that's why it's so effective. Also, I believe a lot, especially non-diabetics, is intermittent fasting. Intermittent fasting does work. It's not that difficult. It does reduce inflammation. It reduces cancer and really reduces your risk of diabetes and helps with weight loss. So that's a couple of ways I do it. I don't know whether Naomi tells people different. You know, you're muted.
Sorry.
Oh.
Sorry, I'm in the middle of the clinic. But yeah, very similar recommendations. I think, you know, I take a different approach when it comes to this, in the sense that I think weight is important, but based on the literature, I really emphasize the importance of exercise and the diet.
Mm-hmm.
And so, especially when women, there's a lot of negative connotations related to weight. And so, not that I don't think it's an important risk factor, but I do tend to focus more on getting someone to do the physical activity, those 30 minutes, 5 days a week, getting someone to adhere to the Mediterranean diet. And once they've made those changes, then I worry about calorie counting. And then, you know, of course, in patients that need more weight loss, we always can think about surgery in that particular cohort, but I tend to do it kind of in that way.
Great, thank you for that. Another question we had is, for anyone that has family history and cardiac issues but has never seen a cardiologist, what would you recommend first steps in finding an appropriate cardiologist?
I'll take a stab at it. I mean, it has to be someone whom you have easy access to. If you have to wait 6 months to see somebody, I'm not so sure they're, you know, and you have to be careful, because especially Christ Hospital, we subspecialize. Like Odama and I both do a lot of preventive cardiology. We do congestive heart failure, cardiac oncology. So you got to find someone who is a general cardiologist, preferably, who also does a lot of preventive. There's several in our group who are fantastic. And you know, Odami specializes in women, but she sees men also somewhat, I think. But seeing an electrophysiologist, for instance, is really not, is a waste of your time, because they take care of pacemakers, atrial fibrillation, stuff like that. Or if you see someone with what we call structural heart disease, that those people that have valves that are blocked, or a surgeon, they'll just refer you on. You just have wasted a visit for yourself. So I think if you look it up on the website, we have people who are listed as general cardiologists, preventative cardiologists, and they're all superb in our practice.
I completely agree. I would say, it depends what is the issue, right? Like Dr. Menon explained, because if you, like, for instance, I specialize in women's cardiovascular disease, and that's why we have these different programs of within, we have at different stages of women's lives, we have different programs that target essentially those particular patients. But then the time I do see men is for small vessel disease, because I specialize in microvascular disease here at Christ Hospital. So that's the exception when I will see men, is because it's to offer that expert opinion. So when it comes to, it just depends what the issue is. If someone's seeking a second opinion, then at that point, it probably will be more targeted to what they're looking for. And we do see a lot of second opinions, especially from other systems, for for the question, like, do I have small vessel disease causing my ongoing angina that I've been told for 5 to 10 years that is nothing and it's in my head? So we do get a lot of requests for that for those patients, and that's very appropriate.
Yeah. And the most important, I think, is that you have to be able to communicate well with your doctor. They have to communicate with you. We could be the smartest, but if you're not communicating, you don't make a connection with your doctor, it's just not gonna, you just won't be happy. You won't get the service that you want.
Thank you both. We do have several more questions. I know we have about 4 minutes left. So we'll try to get through these. The ones that we can't get through, if you want to email me directly, you can ask your questions and I will get these to the physicians. One of the other questions we had is, what are the blood tests called for LPA, APOB, and HSCRP? When do we ask for these tests? And is calcium score test done by radiation, or C-reactive protein test done by radiation?
Odemi, you may take a stab at that.
I think there's a lot of questions in there, so we may need to unpack it. I think they were asking about some inflammatory markers. So CRP is an inflammatory marker that essentially now is part of the new guidelines, the AHA-ACC, as a risk enhancer. So we can use those values to figure out if someone has an elevated CRP, that's a risk enhancer. So when we're having the conversation, what is your risk factor? Like which bucket of risk are you in? We can use these additional values. And I think you also mentioned some of the Lp(a), these additional lipid measures. So essentially what we do with these additional lipid measures that you're mentioning, things like CRP, it's really, we're looking to see where does this person fall in their risk and how many risk enhancers do they have, because that can help us educate and make our suggestions regarding whether we should be starting a statin. And so that's really where they come into play. Now, who should be asking for that? It depends. If someone has a family history, but their cholesterol levels are normal, that's someone that we should likely do these additional lipid measures on, this more advanced lipid panel. That's usually what we do. We just order an advanced lipid panel and it kind of gives us all of this information. And then we can use that when we're making a decision about it. Really, when it comes to most important is we're risk stratifying. And why are we risk stratifying? Well, we're risk stratifying really to determine who would benefit from being on a cholesterol medication like a statin to decrease their risk. I mean, ultimately, that's what the cholesterol guidelines are using a lot of these risk enhancers for and these risk predictors for. And then in terms of a calcium score, so again, a calcium score is extremely helpful, but we usually start with the ASCVD risk score, so someone's atherosclerotic risk score. We use risk enhancers to put them in different buckets. And really where the calcium score is the most helpful is for people in that intermediate risk, where we're trying to have a conversation whether they should start a statin or not based on the risk factors. And then we can use the calcium score to either support that we should start a statin, or if a calcium score is 0, it may be a conversation like, you know what, we can hold off for some time as long as your calcium score is 0. But of course, you keep an eye on those lipid levels during that time.
Those are exactly what I was going to say. Calcium score, they do charge you $100 up front, and I forgot to tell a couple of patients they weren't very happy, but it is radiation. It's equivalent to about 2 chest X-rays, but we get it if you have a 1 score that is low or normal, we tend to repeat in 5 years. So it's not like every year you get one. The vascular screening is $30, and that takes about 7 minutes. The calcium score takes about 10 minutes, and they give you the results right away. It's a computed result. And it's really is helpful, especially people that need convincing that I need to take a cholesterol pill. I mean, if you don't have an evidence, if you don't have reason to take it, if you have a little bit of plaque, and some of my patients, I tell them, well, you don't want this to get worse. It may be a good idea to get on a cholesterol pill. That may be something. The lipid panel, I forget the name of it in our computer system, but there is a special thing that they order along with your lipids that they send out to, I believe, to the Cleveland Clinic Heart Lab, and they send us back the results. It gives you a lot of numbers, but your doctor can unpack it for you and tell you what is a problem. But I think LP little a is quite, especially in South Asians, I think it's quite valuable.
Thank you both so much. We are at the 1 o'clock hour, so this will close our session for the day. We will be having another seminar next month with Emily Ubel. She is a dietitian here at the Christ Hospital, so be sure to look out for more information. She is going to be covering eating macros. Yeah. Again, thank you, everyone. If you have follow-up questions, you can send them to me, and we will work through getting those answers.
Thanks, Lauren. Thanks, Lauren Thompson. Nadaime, good seeing you. Thank you so much. Wonderful. Great discussion.
Invitation.
Bye.
Thank you.